Welcome back to my channel. Now I am continuing with the second part of the pediatric topics, that is congenital heart disease. First, I discussed about acyanotic congenital heart disease in the last video. Now I am going to discuss cyanotic congenital heart disease. All right. Okay, let's start. First of all, we should remember the names of cyanotic congenital heart diseases. There are 5 T's that we need to remember. There are 5 T's that we need to remember as a part of cyanotic congenital heart disease: truncus arteriosus, transposition of great vessels, tricuspid atresia, tetralogy of Fallot, total anomalous pulmonary venous return. I repeat 5 names starting with T: truncus arteriosus, transposition of great vessels, tetralogy of Fallot, tricuspid atresia, and total anomalous pulmonary venous return. Alright, one more thing here to remember is that tetralogy of Fallot has all these names that comes in our mind when we talk about tetralogy of Fallot. As the name shows, tetralogy, so 4 things: VSD, ventricular septal defect, right ventricular hypertrophy, overriding of aorta, and right ventricular outflow tract obstruction. Okay, so easy to remember, this is 2R and 2V's. So first is ventricular septal defect and overriding of aorta, aortic root overriding, ventricular septal defect, or basically ventricular septal defect and overriding of aorta, overriding ventricular septal, 2V's. Two things are related to V's and 2R's. Tetralogy of Fallot has 1V VSD, 1V overriding of aorta over the ventricular septal defect, and 2Rs. 1R is right ventricular outflow tract obstruction, and the other R is right ventricular hypertrophy. So basically, it's not U, is V. 2V and 2Rs. Okay. So this is called tetralogy of Fallot. 2V's and 2Rs. Alright, now I read about cyanotic congenital heart disease. Systemic venous return re-enters systemic circulation directly. Most prominent features is cyanosis. As the name shows, cyanotic congenital heart disease, so there will be cyanosis, means oxygen saturation is less than 75%. Alright, so cyanosis means the oxygen saturation is less than 75%. Hyperoxic test differentiates between the heart and other causes of cyanosis. So what is the test name? Hyperoxic test. That is something important to remember. If they ask us in MCQ which test is needed to differentiate between the cardiac cyanosis and the other causes of cyanosis, so hyperoxic test will be the answer. That is important MCQ point of view. Okay. Hyperoxic test is basically to differentiate between the cardiac cause and the other causes of cyanosis. Alright. Next thing is obtain preductal right radial ABG in room air. Repeat after the child inspires 100% oxygen. So we have to do basically ABGs first in the room air and then repeat after 100% oxygen. If the partial pressure of oxygen improves to more than 150 millimeters of mercury, cyanosis less likely, cardiac in origin less likely. Okay, we don't need to know all these points, but only remember the name hyperoxic test to differentiate between the cause of cyanosis, either cardiac in origin or maybe some other cause. All right. Now the preductal and postductal pulse oximetry is also done. More than 5% difference suggests right to left shunt. All right. So always I remember that we also read previously the right to left shunting happens in cyanotic congenital heart disease, while left to right shunting happens in acyanotic congenital heart disease. So what was the test? Hyperoxic test. All right. Now right to left shunting lesions, first name is tetralogy of Fallot. That is basically a part tetralogy of Fallot, that is 4 things, 2V and 2R, and that is a type of cyanotic congenital heart disease. Let's read about it. TOF is the short name for tetralogy of Fallot. 10% of all congenital heart disease, most common Cyanotic congenital heart defect is known as etiology of failure. Guys, you should remember what is the most common acyanotic congenital heart defect, that is VSD. But the most common cyanotic congenital heart defect is known as etiology of failure. Peak incidence is at the age of 2 to 4 months. So what happens that there is a defect due to anterior and superior deviation of outlet septum leading to ventricular septal defect, right ventricular outflow tract obstruction, overriding of aorta, and right ventricular hypertrophy, as I already told you, 2 V's and 2 R's. 2V was first V VSC, second V overriding of aorta, that is crossing the VSC. So I take it as a V again, and 2 R's. One is known as right ventricular hypertrophy, and the other R is right ventricular outflow tract obstruction. Infants may initially have a left to right shunt. Okay, therefore no cyanosis. Whenever there is a left to right shunt, there is no cyanosis. But however, right ventricular outflow tract obstruction is progressive, leading to increasing right to left shunting with hypoxemia and cyanosis. First there was left to right shunt, so the child may present with no cyanosis. However, the right ventricular outflow tract obstruction is progressive, leading to increasing right to left shunting with hypoxemia and cyanosis. Degree of right ventricular outflow tract obstruction determines the direction and degree of shunt, and therefore the extent of clinical cyanosis and degree of right ventricular hypertrophy. So because of this shunting there will be cyanosis, and then and the degree of also there's a right ventricular hypertrophy. Now something important to remember is clinical features of tetralogy of Fallot. Very important. Alright, the history is suggestive of the etiology of Fallot include hypoxic or TET spells. Remember the word. Because is cyanosis, because is hypoxic, therefore there are TET spells. During exertional states like crying, exercise, the increasing pulmonary vascular resistance and decrease in systemic resistance causes an increase in right to left shunting. All right, so what happens that hypoxic spells or TET spells will be there during exertional states. Okay, whenever there are states of exertion like excessive crying, excessive exercise. Okay, if the child is excessive crying, doing some excessive activity or exercise, there will be exertional state. The increasing pulmonary vascular resistance and increase in the pulmonary vascular resistance happened. There will be increase in pulmonary vascular resistance, and there is a decrease in systemic resistance, causes an increase in right to left shunting. So what will be there? There will be increase in right to left shunting. Okay, clinical features include paroxysms of rapid and deep breathing. There will be rapid and deep breathing. What type of breathing is there? Rapid and deep breathing. Irritability and crying. The child will be very irritable. The child will be crying. Increasing cyanosis. Cyanosis will be there because I know I'm talking about cyanotic heart disease, etiology of Fallot. So there will be TET spells. There will be during when the child is having exertion, or if the child is having crying episodes, or if the child is having excessive exercise. There will be increasing pulmonary vascular resistance, and there is a decrease in systemic resistance. Increase in pulmonary vascular resistance, decrease in systemic resistance causes an increase in right to left shunting. What will be there? An increase in right to left shunting. Clinical features include paroxysms of rapid and deep breathing, irritability and crying, increased cyanosis, decreased intensity of murmur, and the patient squatting for relief. Okay, so there will be rapid breathing, and deep breathing, and the child will be highly irritable, will be crying. Rapid deep breathing, irritable crying child. There will be cyanosis, decreased intensity of murmur. patient squatting for relief. There will be decreased intensity of murmur, and patient is squatting for relief. Okay, if severe, can lead to decreased level of consciousness. If this severe, can lead to decreased level of consciousness, and then there will be seizures and death. Okay, so there will be cyanosis, there will be patient is squatting, and there will be if there is severe, it can lead to decreased level of consciousness, seizures, and even death can happen. So always remember that tetralogy of Fallot is a very very serious condition in which there is, if the cyanosis progresses, there will be problems like rapid and deep breathing, and there will be decreased intensity of murmur, patient squatting for relief, and decreased level of consciousness, seizures, and even death can happen. And especially if the child is having exertional state like crying or exercise, these things can happen. Okay, now the physical examination is also very important. Single loud S2. So remember, single loud S2 due to severe pulmonary stenosis. Okay, so single loud S2 due to pulmonary stenosis, that is we need to remember single loud S2, and there is a severe pulmonary stenosis. Okay, investigation ECG shows right axial deviation and right ventricular hypertrophy. Okay, chest X-ray shows boot-shaped heart. Always remember this term, boot-shaped heart. So, if you say tetralogy of Fallot on X-ray, what is seen? Boot-shaped heart. Always remember the word boot with tetralogy of Fallot. Tetralogy of Fallot is always associated with what? Boot-shaped heart, decreased pulmonary vasculature. So the whole pulmonary vasculature basically decreases. There is a right aortic arch. Then the echo is a diagnostic tool. Management of spells. First we have to give oxygen. Number two, we have to give knee chest position. We have to keep the child in a knee chest position. Knee chest position. Then we have to give fluids to the child. Then we have to give morphine sulfate if there is pain. Propranolol is a beta blocker, and phenylephrine. So this is just management of spells. TET spells, hypoxic spells can be treated with the knee chest position, fluids, morphine as painkiller, propranolol for heart, and phenylephrine. Now the other treatment is surgical repair. There is a definitive treatment, surgery. At 4 to 6 months of age, earlier if marked cyanosis or TET spells, lots of TET spells, then what we have to do? Surgery. And surgery can be done at 4 to 6 months of age. Earlier if marked cyanosis or TET spells. Alright, so what we need to remember in right to left shunt lesions is tetralogy of Fallot. Tetralogy of Fallot. So there will be cyanosis or TET spells. Treatment is with just symptomatic management and then specific management with the help of surgery. Now the other cyanotic congenital heart diseases, let's talk about the other one, the second one, that is known as T. Remember the term TGA. Sorry for the writing. Just to make you remember a visual image, TGA, transmission of great heart, is a type of cyanotic congenital heart disease most common in neonates. So if a child newborn is here, so most common is tetralogy of Fallot was more common in after birth, I think, of course. So cyanotic congenital heart disease, what they were saying, most common after beyond infancy. Most common cyanotic heart defect diagnosed beyond infancy. Infancy is like less than 1 year of age. So after 1 year of age, the most commonly diagnosed cyanotic congenital heart defect is tetralogy of Fallot. Peak incidence is what? 2 to 4 months. So 2 to 4 months. Basically, that is the peak incidence, but it can happen diagnosed beyond infancy. All right. Next thing is that so treatment is sign of okay. Next thing I'm just talking about transposition of great vessels, transposition of great arteries is most common cyanotic in neonate. Neonate is just newborn. Less than 28 days of life is a neonate. Parallel pulmonary systemic circulation. We need to learn Basically there is systemic response. What will happen? The body blood flows to the right ventricle aorta and to the body again. The pulmonary lungs, left atrial, left ventricle, pulmonary artery, lungs again. So variable dependent mixing through PDA, ASUC. So the variable dependent upon if there is a mixing. Physical examination neonates, there will be ductus arteriosus closure, causes rapidly progressing severe hypoxemia, unresponsive to oxygen therapy, acidosis, and death. Okay, in neonates, what will happen if the rapid closure of ductus arteriosus if happens? If there is a rapid closure of what? Ductus arteriosus, rapid closure causes progressive severe hypoxemia, unresponsive to oxygen, there will be acidosis and death. So there will be hypoxemia, oxygen unresponsiveness, unresponsive to oxygen, acidosis, and death. VSD is present if the cyanosis is not prominent, congenital heart failure, congestive heart failure within first weeks of life. If cyanosis is not prominent and congestive heart failure within first weeks of life. VSD is absent, no murmur. Neonates ductus arteriosus closure, rapidly progressive hypoxemia, and acidosis and death. Rapidly progressive hypoxemia, acidosis and death. VSD cyanosis is not prominent. Congestive heart failure within first weeks of life. VSD absent, no murmur. Okay, all right. The next thing is investigations for this condition. ECG shows a right axis deviation, the right ventricular hypertrophy, and may be normal. Maybe ECG can be normal, or either there may be right axis deviation or right ventricular hypertrophy. So TGA, what we need to remember, that is a type of cyanotic congenital heart disease, most common in neonates. And then there will be ductus arteriosus closure, causes rapidly progressive severe hypoxemia, unresponsive to oxygen therapy. So there will be severe hypoxemia because there is cyanosis, right? So there will be acidosis and death. And if the VSD is present, cyanosis is not prominent. So the cyanosis is not prominent, but heart failure within first weeks of life. If the VSD is absent, there will be no murmur. Investigations: egg-shaped heart with narrow mediastinum. So very important thing to remember here is egg-shaped heart with narrow mediastinum, that is egg on a string. Egg-shaped heart with a narrow mediastinum, just like egg on a string. I try to make a visual picture for you guys. Oval egg heart, that is on a string. Egg shaped heart on a string, narrow mediastinum, and it's just like a string. So egg shaped heart on a string, that is basically this what we are reading. The topic is TGA, transposition of great arteries, egg shaped heart on a narrow mediastinum. Okay. Echo is a diagnostic. Management is important. Symptomatic neonates, prostaglandin infusion to keep ductus open until balloon septostomy is there. Okay, so what we have to say, that I need to read the word properly. Okay, say the symptomatic in treatment is basically give prostaglandin E1. What we have to give? Prostaglandin E1. The purpose is to keep the ductus open until balloon arterial septostomy. Surgical repair, arterial switch performed in the first 2 weeks without a VSD, left ventricular muscle is still strong. Then the next thing to remember is total and nominus pulmonary venous return. All the pulmonary veins, they drain into the right side of the circulation. So all the veins drain into the right side of circulation. No direct oxygenated pulmonary venous return to left atrium associated with obstruction must be present for oxygen. Okay, we don't need to learn lots about pathophysiology. Only we need to learn a little bit of management of these things. Surgical repair in all cases and required urgently for survey. As cyanotic congenital heart disease is their total anomalous pulmonary venous return. So what is the management? We have to do surgical repair. That's it. That's it we need to remember. Okay. Next thing is truncus arteriosus. Now what does it mean? It says that a single great vessel gives rise to aorta, pulmonary coronary arteries. Truncal valve overlies a large VSD. Okay, and management is again surgical repair within first 6 weeks of life. Truncus surgical repair within first 6 weeks of life. Truncus surgical repair again. Okay, hypoplastic left heart syndrome, most common cause of death from congenital heart disease in first month of life. Okay, in first month, most common is hypoplastic left heart syndrome. So, what will happen? There will be systemic hypoperfusion. The systemic circulation is dependent on ductus patency. Upon closure of ductus, infant presents with circulatory shock and metabolic acidosis. Okay, the little child may present with infant presents with circulatory shock and metabolic acidosis. Management: intubate and correct the metabolic acidosis. So, if there is a metabolic acidosis, we have to intubate and correct the metabolic acidosis. IV infusion of prostaglandin E1 to keep the ductus open. IV infusion of prostaglandin E1 to keep the ductus open. Surgical palliation of heart transplant. We have to basically transplant the heart. Then the next thing we need to remember is congestive heart failure topic. Four key features of congestive heart failure. They have given us a good mnemonic to remember. Two tachys and two Magallies. What does it mean? Tachycardia and tachypnea. Two tachys and two Magallies. One is cardiomegaly, one is hepatomegaly. So in congestive heart failure, there will be tachycardia, tachypnea, cardiomegaly, and hepatomegaly. Two tachys, tachycardia, tachypnea, and two Magallies, cardiomegaly and hepatomegaly. Alright, next thing we need to remember is congestive heart failure etiology. Congestive heart disease is the cause. Cardiomyopathy may be primary or secondary. High output circulatory states may be anemia, AV malformations, core pulmonary hyperthyroidism. All these things can lead to congestive heart failure. What are the causes? The causes may be congenital heart disease, cardiomyopathies, anemia, anemia, AV malformations. So one cause is congenital heart disease C, another cause is cardiomyopathy, one more C. One cause is anemia. Okay, another cause is AV malformations. Then another cause called pulmonale, one more C, and then hyperthyroidism. Okay. Non-cardiac causes sepsis and renal failure. So one causes is renal failure. So F. Look, congestive heart failure causes CAHF. Okay. Then sepsis and maybe renal failure. Then pressure overload, aortic stenosis, coarctation of aorta, pulmonary stenosis, hypertension. Stenosis, aortic or pulmonary, and hypertension. Volume overload, valvular insufficiency. Okay, I gave you a very good mnemonic for congenital heart defect causes. One is I was talking about congestive heart failure, sorry. So congestive heart failure, CHF. Mnemonic to remember the etiology is congenital heart disease, cardiomyopathy, coarctation of aorta, then anemia, AV malformations, even one C is for core pulmonale, then H is for hyperthyroidism. Okay, and then F is for renal failure. Okay, F is for renal failure. Okay, and then volume overload. Okay, valvular insufficiency. All right, now the clinical features of congestive heart failure include basically infant is here. An infant is a child, a very new child, infant less than 28 days of life is neonate, and after before 1 year of life is infant. Infant will have a very weak cry. He will be very irritable, feeding difficulties. So the child will be having a very weak cry. Child will be very irritable, feeding difficulties, early fatigability, diaphoresis, and respiratory distress, lethargy, and failure to thrive. Alright, so infant will be having a weak cry, extremely irritable, difficulty in feeding, early fatigability, easily getting fatigue, difficulty in feeding, sweating a lot while sleeping or eating, respiratory distress, and lethargy. And the child, what are the clinical features for the child? Decreased exercise tolerance, fatigue, decreased appetite, decreased exercise tolerance, fatigue, decreased appetite, respiratory distress, frequent upper respiratory tract infections, or asthma episodes. Okay, guys, actually, I took just 5 minutes break and I am back again. So, I want to repeat the clinical features for infant and the child. Alright, so for infant, the infant will be having a weak cry, extremely irritable, there will be some feeding difficulties, early fatigability. Diaphoresis means extreme sweating while sleeping or even while eating, respiratory distress, lethargy, and failure to thrive. Alright, but in the case of child, there will be decreased exercise tolerance, there will be extreme fatigue, there will be loss of appetite, respiratory distress, frequent upper respiratory tract infections, or asthma episodes. Alright, so infant has more problems with sweating and fatigue, feeding problems and sweating problems and respiratory distress and failure to thrive. While the child will be having more appetite problems, respiratory problems, and respiratory problems not only include asthma like symptoms but also frequent upper respiratory tract infections. Now, next thing is general features like orthopnea. That means dyspnea on lying down. Paroxysmal nocturnal dyspnea. That is dyspnea at the night time, on and off. Paroxysmal nocturnal dyspnea. Pedal or dependent edema are all uncommon in children. Always remember. As I was reading them, I was thinking, oh, do they occur in children? No, they don't. Because they are mainly occurring in adults. So, orthopnea, paroxysmal nocturnal dyspnea, pedal dependent edema, they are all uncommon in children. Children will have different set of features that I read already for you guys. These. The children have different set of features and that we need to remember. But okay, all right. So children have different set of features that we need to remember, and these things like orthopnea, PND, and pedal edema are uncommon in children. Now, the physical findings are basically four key features. Tachycardia, as I already read already. Tachycardia, two tachys and two megalis. Tachycardia, tachypnea, cardiomegaly, patomegaly. Additionally, where will be if child will be having failure to thrive, alterations in the peripheral pulses. The child will be having failure to thrive. There will be alterations in the peripheral pulses, four limb blood pressures. So we have to check the blood pressure in four limbs. There is basically differences in the blood pressure in the four limbs, and dysmorphic features associated with congenital syndrome, and there will be gallop rhythm. So dysmorphic features associated with a congenital syndrome and gallop rhythm. Investigations are basically chest x-ray. Chest x-ray will indicate there will be cardiomegaly, pulmonary venous congestion. There will be cardiomegaly and pulmonary venous congestion. ECG will show sinus tachycardia, signs of underlying cause like heart block, atrial enlargement, hypertrophy, ischemia, infarct. Chest X-ray, cardiomegaly, and pulmonary venous congestion. There will be cardiomegaly, increase in the heart, size, and pulmonary venous congestion. Then ECG shows sinus tachycardia, causes underlying causes like heart block, atrial enlargement, hypertrophy, ischemia, वगैरह, etc. So echo, what does it mean? Echo will show structural and functional assessment. Structural and functional assessment. Blood work will do the blood work like CBC, electrolytes, BUN, creatine, urea creatinine, LFTs. All right. Management. Management is very important, like general management, sitting up, posture very important. Then oxygen, sodium water restriction, increased caloric intake. Sodium and water restriction means fluid restriction, including not only water but sodium as well. Increased caloric intake. Pharmacological management, including basically diuretics, after load reduction, beta blockers, digoxin. So there will be diuretics, there will be after load reduction, like ACE inhibitors, beta blockers, and diuretics. So we'll give basically diuretics. That's after that there will be ACE inhibitors, beta blockers, diuretics. What we give in congestive heart failure? ACE inhibitors, beta blockers, and diuretics. Okay. Curative management is basically correction of underlying cause. Correction of underlying cause, dysarrhythmia. Pediatric versus adult ECG. Pediatric ECG finding that maybe normal heart rate is more than 100. Shorter PR in QT intervals and QRS duration. There will be short PR and short QT interval and QRS duration. Inferior and lateral small Q waves. Right ventricle larger than the left ventricular neonates. Okay, whatever. ECG changes are different in pediatric versus adult ECG. Okay, we don't need to remember all this stuff. Definitely not for this exam. Okay, dysrhythmias can be transient or permanent, congenital or acquired. Sinus arrhythmia, phasic variation with respiration, say sinus tachycardia, that is rate of impulse arising from sinus node is elevated if it's more than 150 infants and more than 100 in older children. Characterized by beat to beat heart variability, P waves present on normal, PR constant. Not very important to remember all this stuff. Man premature atrial contraction may be normal variant, can be caused by electrical disturbance, hyperthyroidism, heart surgery, digitalis. Premature ventricular contraction common in adolescents, benign if single uniform disappear with exercise, and no associated structural lesions. If not benign, degenerate into more severe dysrhythmia. Okay, this is a bit important to remember. Premature, what is premature? Atrial contraction, what is premature? Ventricular contraction, what is SVT? That is something important to remember. Alright, I will slowly tell you again one more time. So don't worry, guys. Okay, PAC, what is premature atrial contraction? Okay, may be normal variant or can be caused by electrolyte disturbances. So either they say the cause may be normal, there is no cause, or may be caused by electrolyte disturbances. There may be hyperthyroidism, heart surgery, digitalis toxicity. Normal variant or can be caused by electrolyte disturbances, hyperthyroidism, heart surgery, and digitalis toxicity. Hyperthyroidism, heart surgery, or digitalis toxicity. Hyperthyroidism, heart surgery. So what we say, hyperthyroidism, heart surgery, electrolyte abnormalities, or digitalis. Then premature ventricular contraction common in adolescents. Benign if single uniform disappear with exercise, no associated structural lesions. If not benign, degenerate into more severe dysrhythmia. Either they are benign, they may be due to structural lesions, they are usually benign, okay, and they disappear with exercise and no structural lesions. If not benign, degenerate into more severe dysrhythmias. SVT, abnormally rapid heart rhythm originating above the ventricles, and dysrhythmia in children, no beat to beat heart rate variability. Okay, pre-excitation syndromes like Wolff Parkinson White and congenital heart defect. SVT, abnormally rapid heart rhythm above the ventricles. SVT basically originate above the ventricles. Okay, no beat to beat heart rate variability. No beat to beat heart rate variability. More than 220, more than 118 children. P waves are absent or abnormal. So, P waves absent, abnormal. PR indeterminable, QRS narrow. Always remember in SVT, QRS is narrow, and P waves are absent, and QRS is narrow. Pre-excitation syndromes, Wolff-Parkinson-White syndrome, congenital heart defect. So, Parkinson-White syndrome and congenital heart defect. Then, complete heart block. Congenital heart block can be caused by maternal anti-Rho anti-La. Wow, something new for me that maternal Rola anti-Rho anti-La mother with SLE can lead to congenital heart block. Diagnosed in utero. Our clinical symptoms related to level of the block. Symptomatic patient need a pacemaker. If there is a heart block, congenitally needs a pacemaker associated with SLE and lead to fetal hydrops as well. Then the heart murmurs. The last topic we are going to discuss today is heart murmur in this session. Alright, 50-20% of children have audible heart murmur at some point in their childhood. Most childhood murmurs are functional. Always remember the word functional means innocent. Innocent is functional. Without associated structural abnormalities and have normal ECG. So is innocent means everything is normal. Innocent means everything is normal. Innocent means if say the person's innocent, so he's very normal. Okay, so there will be no structural abnormalities and have normal ECG and X-ray findings. So normal ECG and X-ray findings are normal as well. So there will be normal ECG and radiological findings. Normal ECG and radiological findings. In general, murmurs can become audible or accentuated in high output states, fever, anemia. Either they become audible or they become accentuated, means increase, audible or accentuated in high output states, for example, fever and anemia. Alright, differentiating heart murmur. Innocent murmurs, we need to differentiate it from pathological murmurs. Alright, innocent murmurs are basically asymptomatic, as we already know. Pathological will be symptoms and signs of heart disease like failure to thrive, exercise intolerance. Failure to thrive, exercise intolerance, signs and symptoms of heart disease will be there. Timing is systolic ejection murmur, all diastolic, pansystolic, continuous. So systolic murmurs are innocent. Systolic murmurs are innocent. SM, systolic murmur, innocent. SMI. So systolic murmurs are innocent. While the pathological murmurs, they are diastolic, pansystolic or continuous. They are diastolic, pansystolic or continuous. Next is grade, less than 3/6, soft, glowing, vibratory. Pathological will be more than 3/6, palpable, thrill and harsh.